Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
Are we recording? Yeah, we are.
Yeah, it's running. Red light's on.
All right, fingers crossed we don't crash like like last time. Listeners, this is from your POV, I suppose, episode 4 or 5 of season 2, but this is actually our first recording back from season 2. We had some episodes stocked up and we did some rearranging. So welcome back to season 2. Very happy you're here with us. And just want to say thank you for kind of waiting around for us and following along for the journey. We've gotten a lot of really, really nice feedback after our first year of episode releases. And it's just such a pleasure to be able to share these cases with you all. And I've been having so much fun. And I have very exciting news about Mike, if it's not too personal for Mike. Mike, what happened in your life recently that the listeners should know about?
What did I do over summer vacation? I got engaged.
All of those email DMs that you've been sending for Mike, guys, you can't be sending those anymore, okay? Mike's hitched now. He's a hitched zebra or a hitched horse, whatever animal of your choice. But big congrats, Mike. Really happy for you. And what a way to start off season 2 for sure.
Appreciate it. Thank you so much. What'd you do with your summer break? What did you do over the summer?
Ooh, I've been running a lot intermittently still. I'm still very bad about getting my runs in like post shift. So I have these like weeks off still, but on my days off, I'm on my weeks off. I've been running like every other day. I've been back on the skates on the basketball court. So no major falls, but still very much high risk fall. So like fall precautions on the basketball court. But no, just a lot of walks with the boy too. Rogue's really been enjoying the weather. He still likes to try and walk farther than his capacity to do so. Like he'll want to just keep walking even though he's physically exhausted. So I'm trying to get better about showing him that that's not really something he can do for miles and miles, and trying to do shorter walks with him. But we're having a lot of fun with him. That's about it, man. That's about it. Just work still and enjoying the attending lifestyle still, I would say.
Good. I feel like Rogue and I have some similar qualities then when it comes to walking. I often find myself far from home with only my 2 legs to get back. And those 2 legs are very tired.
The halfway point realization. That does happen to me on my runs too, I will say, since I'm still in the process of kind of getting back to the shape I used to be in. So anyway, all right, Mike. All right, you're taking the first case. So for aliquot number 1 for this case, this is the case of a man in his 80s who presented for chest pain, who I saw when I was on the admitting service. Basically, if we have someone admitted by an overnight person, but they're still boarding down in the emergency department, one of us needs to go down and round on them. And these are the shoes I was basically filling that day. So this patient was actually a retired psychiatrist, so able to give a very straightforward history. He was at home watching TV from his sofa when he developed resting central chest pain, sensation of jaw pain, and diaphoresis. Since this was immediately concerning to him as a physician, he had EMS taken to the hospital right away. So on arrival, he was afebrile. His heart rate was 120s, blood pressure was 190s over 100s, and he was saturating 100% on room air. Notably, his respiratory rate was up to 30. His past medical history is notable for hyperlipidemia and osteoporosis, but he's otherwise healthy. You're actually meeting him about 8 hours later in the morning and already have a few ECGs as well as troponins repeated since his arrival in the middle of the night. His tropes were 80, 79, and 84 nanograms per liter. Before letting you describe the ECG for the listeners, my first question for you is, what are you looking for on an ECG when assessing the patient coming in with chest pain?
I think the way you think about an EKG is really as almost a screening for the can't miss first, right? So, of course, the thing when someone comes in with chest pain that we're all looking for are ST changes, something that needs me to act immediately, right? So if I see ST elevations, in the right clinical scenario, this guy has, these are high sensitivity troponins, right? So these are positive, right? Not something that we don't see often, right? But there are positive troponins. And then, if he had really significant ST elevations in a distribution that made sense, then right, you're talking to cardiology, activating the cath lab. You're also looking for other things, right? So ST depressions, T wave inversions, oftentimes trying to compare it to previous EKGs if you have them, right? It's really scary when you have a left bundle and you have no EKG on record, right? But a little less scary when you see that this person's had a left bundle for 10 years. But I think the thing you're doing first is really trying to rule out the stuff that's going to kill this person, and that has an immediate sort of where time is really right. That's why we get EKGs on everyone who come into the ED with these sort of complaints. And there's a metric that we measure about how fast does this EKG get read by an attending. That's just because time is muscle, time is heart. So, you're also looking for arrhythmias. This guy's heart rate's 120. So if you saw that he's in fib or in flutter, that's very helpful. And, additionally, if you've got, a regular rhythm that's not, if his heart rate was slow, right? Does he have heart block? But I think the first pass is really, is there something here that I need to act on in seconds to minutes, or do I have a little bit more time to think about this? And, you also, as you sort of reassure yourself, hopefully, that this is not an ACS scenario or, a tachyarrhythmia that needs to be addressed immediately, right? He's hypertensive, markedly so actually, and then has a heart rate that's, high but compatible with life. So, I'm not expecting us to see something, like a malignant arrhythmia here, but that'd be another thing you'd see. And then, once that happens, then you can take another pass through the EKG, and sometimes it gives you some information about the patient just as at baseline, right? So if they've got, criteria for LVH, all right, this is a person who's hypertensive, like half the patients we see, but this person's heart really feels this hypertension over the last decade of their life, right? There's been some remodeling. You see giant, big P waves, right? Okay, maybe this person does have some just chronically elevated left filling pressures, right? The atria is big. So things like that, and of course, if you see a bundle that just may make you a little bit more suspicious of an underlying structural heart disease, right? We don't just walk around with right bundles or left bundles without some sort of pathology. It may just be structural chronic issues that have nothing to do with the presentation, but it just tells you a little bit about the person's baseline kind of cardiac health.
Very cool. I like how you kind of like form a visual of the patient with that last pass. So let me send to you by text. Hopefully you can pull this up on your computer. The baseline ECG, which is on the top, and I don't even remember. This is from like 2 years ago or a year ago or something like that. And then the bottom ECG is on admission, notably when he does not have active chest pain on arrival. His chest pain, I'll tell you more in a second, is really resolved when he arrives to the emergency department. But yeah, why don't you just take a look at it? The listeners can go on the website and pull it up too. And the top one is his like baseline, like kind of like clinic visits, and then the bottom one is his arrival after the chest pain is resolved. And unfortunately, the one captured by EMS is not available to you. It's you go in the physical chart and it's not there. So this is what you have, and his chest pain is gone when they captured that one.
Gotcha. Okay. Yeah. So I think, again, like we talked about, comparing is really a huge part of this. If you don't see something that's just so obvious that you have to act, regardless of what the prior EKG showed. So, looking at the EKG on admission, he has a T wave inversion in V1, but that looks to be present in his baseline EKG as well, although it's a little more prominent in this one. He probably does meet criteria in V3 for ST elevation. Not seeing that he necessarily meets that criteria in V2 or V4, maybe V4. Maybe he meets it in V4. So, possibly borderline ST changes that would be sort of in the septal to lateral region. And then, just looking at his baseline EKG, he does have pretty marked voltage in the lateral leads. It's actually more prominent there than on the admission. And so that, can be a number of things, but does, make me think about LVH, just a kind of a chronic baseline. But yeah, I'd say that it is somewhat nonspecific, but there does seem to be possible, borderline elevations in sort of the septal kind of lateral, although V5 looks fine. But, in the absence of active chest pain, and with tropes that are at least stable over the last, 4 hours, I think you have time. I don't think this is a STEMI. And, I think I could take a break and we can think about what this is, but I'm not seeing anything obvious. The biggest thing I think on the baseline is just that this guy probably does have some amount of hypertension at baseline, right? This 190 over 100 is very high. I don't know if he lives there, but he probably does have some amount of hypertension at baseline. So those are my initial thoughts.
Yeah, that was very similar to my initial thoughts actually too. I was struck by kind of the QRS changes in V4 and kind of the changes the voltage that you were kind of like talking about. And I also was kind of drawn to those the slight elevation of the ST segment or the J points and V3 and V4 too. Cardiology saw not just the CCG, but I guess the EMS CCG that I was unable to find and did not activate the cath lab. So they did not feel that this was a STEMI. So for aliquot number 2, I'm going to give you all the information that I gathered from the patient. Basically, what he says is that since he arrived to the hospital, he has not had any of the symptoms that he described in the initial report. However, he notably then says, almost in exactly these words, because remember, he's a retired psychiatrist. Okay, I guess it's reassuring. My ECG looks okay since my pain is better, but I'm really having such a hard time breathing. Why am I so tachypnic? Those were his words. It's at this moment you realize he's right. The respiratory rate documented in the chart in the 30s was real. So what you observe is he's speaking in short sentences. It almost sounds like he's stuttering the way his speech is coming out between respirations. He doesn't look like he's an extremis by any means, but he also doesn't look comfortable. When you ask him more about the respiratory history, he said he's been feeling dyspneic on exertion over the last few days at least, and he comments that it's during these episodes that he has noticed he becomes quite tachypnic. He initially attributes this to anxiety and pain as he has chronic low back pain, but he then also brings up that he's been feeling more globally weak over the last few months. He says that he has stairs in his home, and while he used to have issues with going up the stairs due to radicular back pain, he now cannot go up the stairs without help due to frank weakness. He's not had any urinary or stool incontinence. He's had poor appetite for many months and lost 15 pounds unintentionally without fevers or chills. On further history, he said he's been coughing after eating. For objective data, you have a CTPE study that was negative for pulmonary embolism and didn't show any evidence of decompensated heart failure, so like no pleural effusions or no parenchymal infiltrates. On exam, he has clear lungs anteriorly. He has no murmurs. He has no pretibial edema, no JVD. He's full strength in all major muscle groups, but he does have only 4+ out of 5 strength in the bilateral shoulder abductors and hip flexors. A VBG I acquire shows a pH of 7.42, elevated PCO2 of 53. During the lung exam, I actually observed something completely incidental that I'll show you a video of now. Oh, I think it sent you an image. It just sent you a leg, Mike.
Send me a pair of legs.
Just a pair of legs. All right, let's try this. Okay, there you go. Let me know if that opens.
Okay, here we go. And you said I'm watching. This is a respiratory pulmonary exam.
So it's during the pulmonary exam that I noticed something in his shoulders. This is just a video capturing those findings more globally.
Gotcha. I'm going to mute myself so that you don't hear the video.
Okay. My question for you is, first of all, what did you see for the listeners? And again, this will be up on the website for them to interpret too. And with that finding, how would you be putting together this patient's story at this point?
So what I think I'm seeing here is, are those fasciculations? Am I seeing fasciculations here?
Yeah, those are fasciculations. Completely. Yeah. As I was putting my stethoscope on his chest, and I just happened to happened to, because he was wearing a gown, see that the skin of the shoulder was kind of dancing around, and I just paused and said, that's kind of interesting. I looked elsewhere, and then I in that recording saw it in the calves too.
Very interesting. Okay, so um, good pickup on your end. That's very subtle. The legs, I'm not. I'll be honest. I'm not even sure that my eye is noticing much, but the shoulder, you can definitely see it there. So yeah, he's got some fasciculations.
Yeah. How would you tie that finding into this patient's story? Come in with those vital signs and the VBG I just gave you, kind of all the information, and I'm going to give you more, of course. But I'm just curious if that's stirs any hypotheses for you, and definitely by the end of your hypothesis generation, kind of what testing you would be doing next for them.
I'm going to sort of think out loud here because I don't think that I have any good illness script or framework for fasciculations plus these cardiopulmonary findings and complaints. Fasciculations in an 80-year-old, you're certainly. I don't. I guess I forgot to ask if there's what the reflexes are like, but I mean, ALS is the thing you worry about the most when you see fasciculations like that on exam. That's just the thing that we worry about. And then, things that cause muscle twitching in general, right, are just electrolytes that are abnormal. So I'd want to see things like, what's the potassium, what's the magnesium, calcium, phosphate, right? Just because those things cause muscles to behave in abnormal ways, including the heart muscle. So, the reason my mind even thought of ALS is really just because you mentioned this weakness, this trouble going upstairs. And, so that's sort of, I think, why that even comes to mind. I think if you just showed me those findings and didn't tell me anything else neurologically, I don't think I would be thinking about it. I'd probably just say there's something wrong with the electrolytes. That's probably what's causing a lot of these issues, or let's at least see what they are. But how you can have a neurodegenerative disease and then present with these findings of chest pain, hypertension, and sort of some demand ischemia, right, with the mildly elevated tropes. I'm going to have to just ponder that for a second. One thing is he could certainly, you mentioned some coughing after eating, he could certainly be aspirating and giving himself some pneumonitis at times. That would give you tachycardia and tachypnea and hypertension, right? It's just very sympathomimetic. Usually hypoxia, but maybe if you're seeing him right after that, or maybe he has no underlying lung disease, so he's able to sort of, from a oxygen extraction standpoint, still do okay. But I suppose that's something to think about. And then I guess the other thing would be, could he have, instead of something, the primary neurodegenerative disorder, could he have some sort of paraneoplastic thing, right? He has the 15-pound weight loss. And, this may be worsening radiculopathy, but it doesn't sound like that's the case. Sounds like that's the same. You're just thinking about things that could localize to the spine. But, and you said he had a CT. So, what I was sort of thinking about is there some sort of, tumor in the mediastinum or in the chest that could be, causing some sort of, direct compression or issue with the heart. But you're not really giving me any signs of volume overload or JVD elevation. And again, the CT scan, which was contrasted in this case for PE, but it should show something that would be large enough to do that. And so I guess the question would be, does he have something else? And then the other piece of data, again, I'm just sort of throwing a dart at the dartboard here because I don't have something in my mind that pulls all of this together. But he's quite tachypnic and he's hypercarbic, it sounds like, but not acidemic. So he's compensating, but a little odd for a guy who has no existing lung disease, as far as we know. And we didn't see anything on CT either, right, that would suggest an underlying fibrotic lung disease that maybe has gone undiagnosed or an emphysema. a little odd just to have hypercarbia, particularly in the presence of a tachypnea to the 30s.
I was just
So,
about to tell you, Mike, that was through the
right.
tachypnea too. Yeah,
Right,
exactly.
right. So that's bizarre, and really sort of then means that despite the rate at 30, he's not able to mount enough minute ventilation. And so if you're breathing fast and you don't have enough minute ventilation, then you're not breathing deep enough, right? Which really, again, sort of speaks to, in the absence of any kind of restrictive lung disease, speaks to a muscle problem or a nerve problem, right? You're not generating enough force to create a good tidal volume, so you just breathe faster. We've seen that before, right? And I think in other episodes. So, pulling this all together, I think, as I'm just talking out loud, the things that are jumping out to me are, really neurologic issue, some sort of neurologic issue that sounds like it's maybe relatively rapidly progressing over a couple of months. I certainly worry about things like ALS. I think it would be helpful to know if he has like fatigability on exam, myasthenia, Lambert-Eaton, but they don't usually cause fasciculations at rest. And when I think of fasciculations at rest, I really do think electrolyte abnormalities and ALS. That's the thing. I think that for listeners, if you see that on exam in an elderly person, that's like a can't miss, basically, right? That's what it looks like. I've seen it 5 times so far.
Wow.
Since starting as an attending, and every time I've seen it, that's the thing you see. So it's just that's why I think maybe I'm anchoring, but that's probably why I'm anchoring, because I've seen it enough times now, and that's always what you see. That's like the tip off.
Wow.
5 of those 5 times, 3 of those times, it was the diagnosis was made in the hospital, and it was because someone noticed the fasciculations. So I think that's where I'm left. I'm hand waving with the cardiopulmonary stuff. I again, just the coughing, maybe he's aspirating, and he's generating sort of that response. And that's why he's developing this. Or he just has, I suppose, autonomic dysfunction from some sort of underlying neurodegenerative disease. I guess that would be the other thing, is you could just generate almost like a hypertension, and then a hypertension sort of symptomatic hypertension. I don't know if I would call it an emergency necessarily, although there's a little bit of chest pain, a little bit of tropes. I feel like that's always a hard call to make, but I think that's maybe the other thing, is autonomic dysfunction. And he gets really hypertensive, and then he sort of feels it. He feels the hypertension. I'm going to stop rambling. Those are my thoughts. I'm happy to be wrong. Hopefully I'll learn something.
Well, when I saw all the fasciculations, I also was just doing a shotgun hypothesis generation. That was kind of the mode I was in. I was doing the exact same thing. So we'll definitely get back to whether or not this, what I'll call neuropulmonary syndrome, ends up being related to this cardiac syndrome. Are they related? Is one as the consequence of the other, et cetera? So you already kind of started to comment on that, but I'll give you a little bit more information and we can circle back to that question. So for this aliquot, we're just purely going to focus back on this chest pain, cardiac sort of syndrome. So that was the last time I saw this patient, because again, he was an ED boarder. He was admitted upstairs, and then later that night, he had recurrent diaphoresis, acute worsening of dyspnea, and there was a question of recurrent chest pain. So another ECG was acquired and tropes were repeated. So here's a photo. And at the bottom of the photo is the repeat ECG during this chest pain event for your interpretation. And my question for you is just going back purely to, patient coming in with chest pain and ECG changes, kind of would this trigger you to do anything in particular?
There's a more compelling case for a change, I think, now. I think you could, if you look at the V2, V3, V4, I think that you could make a case to meet criteria. Again, I'm on a laptop in my office, so I don't know that I can quite get the resolution to count the boxes, but I'd say it's borderline enough. And the other thing now is that and I guess, sorry, Andrew, are tropes repeated? Are they sky high now? Are they the same?
They're repeated, come back at 104 and 123. So mildly elevated from prior, but notably in the setting of this kind of respiratory failure sort of picture.
Yeah. So, I mean, being transparent here, and maybe in 5 years with more experience, I would feel otherwise, but this one is different, I think, enough from his baseline that and the fact that now it's within the context of recurrent diaphoresis, recurrent maybe chest pain, and we don't have a diagnosis, right? So anytime you have a patient who does not have a unifying diagnosis, then we have to take the things we find, even if they're subtle, even if you're not sure, we have to take those things a little bit more seriously, right? If you told me that this guy had pneumonia, then I don't know that I'm going to do anything with this data. But we don't have any unifying diagnosis. We know he doesn't have a PE. We know he doesn't have a primary parenchymal lung disease as far as we can tell because we have a negative CT. And he doesn't seem to have heart failure. And, he's doesn't really have a great story for it, but he is 80 with hyperlipidemia and probably hypertension. And, I think just being transparent here, I would talk to cardiology because I think I need to know how worried about this do I need to be in the absence, again, of a unifying diagnosis. It's because there is no diagnosis yet that makes sense that I have a lower threshold to get worried about subtle changes on EKG that maybe on another day I maybe wouldn't even appreciate to the same degree. But I'm looking for any piece of data I can find, and I'm wondering if maybe this is something. Andrew, maybe I'm just a nervous young attending, but let me know your thoughts.
Well, I don't think so, because a very smart young hospitalist, Dr. Wagner, was taking care of this patient, one of our listeners, and he was also nervous enough to call cardiology, and they took a look at the ECG and felt still doesn't meet STEMI criteria, but certainly with the troponins increasing and in the ECG changes, they at least wanted to stress test him and start get moving on the sort of like ACS sort of workup. So we'll certainly circle back to that. So I already gave you the trope repeats. And really, in the morning, this kind of paroxysmal episode resolves hours ago, and his resting dyspnea and this fasciculations picture takes center stage again. So they get a NIF on him that was minus 35, and he continued to have not recurrent chest pain during the day, but recurrent paroxysmal dyspneic spells. They get an MRI of his total spine showing moderate to severe cervical stenosis, but not explanatory for his dysphagia reported, as well as leg weakness. So quick pause for the listeners here to comment how important the patient experience is as it relates to weakness. So you can recall our discussion on subtle weakness in our prior episode with prominent orthopnea in a patient with morbid obesity. So this is a patient who on strength exam, the neurology team did not, again, elicit substantial weakness on initial exam and felt EMG could be done in the outpatient setting for this patient. But if we really sit and listen to the story, though, the dysfunction here in the form of inability to walk and climb stairs, secondary to subjective weakness and a reliable reporter, as well as dyspnea while resting, is a huge red flag. So as this was an ongoing issue while he was in the hospital, he, of course, did ultimately undergo EMG after one of my hospitalist colleagues pushed for it. And before I share the case conclusion, do you want to share any final thoughts on what you think happened to this patient? Because there are really two issues in this case. The first is what I already called the neuropulmonary process, kind of defined by the fasciculations, weakness, and respiratory failure. And the second is this cardiac process with the acute chest pain that kind of recurred and had these ECG changes. So final call here, Mike. Do you think they're globally related? Is one the consequence of the other? Are they completely separate processes? What do you think?
I don't know that I have any super genius words to say here. I'm just thinking something is generating the troponin, right? We often sort of take a look at those high sensitivity troponins. They're like, well, I don't know what they make of that, but it is abnormal, right? I mean, if you took a 20-year-old who walks into a college clinic, no one's troponin should be positive there, right? So I'm trying to think of a way that you could get, what's the similar between those fasciculations on exam and respiratory symptoms and this progressive weakness and then the heart. And I guess the thing that unifies all of them is that they're all muscles. And so I guess I would think, is there some sort of process that maybe isn't necessarily neurodegenerative? Does he have some sort of myopathy that is affecting both his, skeletal muscle and his cardiac muscle? But what is that? I don't know. I don't know. Is there something that's infiltrating the muscle, something that's infected in the muscle? I think for the sake of time and my own ego, I'm not going to try to generate a differential off of that. But I wonder if maybe the answer lies in something that's that's in every muscle, because I guess that could do all of these things. But the EMG and the stress test, I think, are going to be very helpful, even if they don't give us a unified diagnosis, at least in telling us what these things are or are not, right? Because I think if we diagnose him with ALS, I don't know that explains the cardiac issues. I still can't think of a great diagnosis. And if he has, LAD lesion, I don't know how that explains anything else that he's complaining of, right? So, but it would be helpful to know if both of those things are negative, right? So I guess that's what I'll leave you with. No great wisdom, though. There's certainly no unifying diagnosis.
Well, I will say the cardiac story isn't fully clear anyway, so it's okay, Mike. I think you mentioned the final diagnosis, and you have the workup in place to get to the final diagnosis, which is what counts. And this case goes to show that there's so many kind of like plug and play options, like X plus Y sort of options for some cases that could be very hard to figure out if it's an Occam situation or rather not an Occam situation. One thing explains the other explains the other. You know what I mean? So a lot of different options. So let me tell you the case conclusion. So the neuropulmonary story, EMG showed a generalized disorder of the motor neurons, essentially confirming ALS as the final diagnosis. While he unfortunately succumbed to respiratory failure on comfort measures only just a few days later, I was so glad my hospital's colleague pushed to get that workup done as soon as possible, because the patient and his family would have definitely been left without diagnostic closure. And as with all my patients, I certainly feel honored to be able to share their lessons with people like you and our listeners. For the patient's cardiac story, a SPECT stress test was performed just prior to the EMG, showing a, quote, large size scar in distribution of proximal LAD with mild peri-infarct ischemia, LVEF of 37% with septal hypokinesis. As you all know, this does not at all confirm the temporality of an ischemic myocardial event, so it doesn't inform on whether the patient presented with an inclusion MI or not. If we want to consider the most morbid cardiac hypothesis, if you take a look at the series of ECGs, you'll notice that in lead V1, during the repeat overnight chest pain event, the inverted T wave had baseline actually flip from negative to positive. And when you see T wave inversions in the anterior precordium flip like this in a patient with recurrence of recently resolved chest pain, this could theoretically represent the progression of that expected in Wellens syndrome, which I know you and others have heard of. Wellens syndrome sounds fancy, but it's actually quite simple, and I'll go over it really quick. When they teach us about the progression of ST changes and STEMIs in med school, remember that what you usually see first is hyperacute T waves that then transition into ST elevations. And if that coronary occlusion does not open up, you then develop pathologic Q waves, etc. You can also recall if that coronary occlusion does open up due to your body's natural thrombolytic mechanisms, ST elevation can resolve, and what you see in the culprit territory is the development of biphasic T waves followed by deeply inverted T waves. These are known as reperfusion waves. If you can remember these predictable changes for coronary occlusion with reperfusion, then you actually know Wellens syndrome. Wellens syndrome doesn't describe any special ECG changes. Why it's special is that it describes these changes being seen in a very dangerous location, which is the proximal LAD, with changes in V1 to V4 being very ominous for a tight lesion that, while open, can close back up at any time and lead to very serious LV infarctions. This is, why the LAD is called the widowmaker. So going back to our patient, if you look at V1 to V4 on presentation, we see that he initially has a T wave inversion in V1, but otherwise no reperfusion waves in this territory. We could say that the flip of that T wave inversion in V1 to positive could have represented reocclusion of the proximal LAD. But in talking to a cards fellow, it's ultimately very hard to say and overall less likely. The teaching point is just to realize that in a patient with recently resolved chest pain, quote, resolution of T wave inversions is not in fact normal if accompanied by recurrence of chest pain. And this is one of the situations of medicine that normal is abnormal. So this phenomenon is actually called pseudo-normalization, to point out how deceiving this is and to recognize that coronary occlusion has in fact recurred. So to summarize, that's the most morbid hypothesis. The less morbid and more likely hypothesis for this case, his ECG changes were not related to occlusion, but still reflective of ischemic chest pain related to a supply-demand issue of the heart. So if you take a step back and consider the DDX of chest pain and ECG changes, what you'll realize is that the ECG changes can be related to the chest pain as evidence of the underlying culprit, or be a completely unrelated bystander, like in benign early repolarization. I'll put up the full schema on the website, but the summary is this. ECG changes related to the culprit disease can represent a primary cardiac issue of the myocardium, secondary cardiac issue related to strain, like in PE, or related to supply-demand mismatch, where chest pain is being driven by an uncontrolled extracardiac issue, like severe anemia, hypoxia, pulmonary hypertension. And tachycardia is often a strong clue to this. Supply-demand ECG changes can be thought of as those that would be seen in a positive stress test because they quite literally account for ischemic chest pain related to supply-demand mismatch. They're simply being caught out in the wilds rather than in a cardiologist stress lab. So in this patient, the issue could have been tachycardia and hypertension secondary to respiratory failure, putting significant strain on a chronic proximal LAD lesion. And that's the case, Mike. It was certainly a weird case that kind of hit the door. There was so much going on and things ended up picking up rather quickly for the patient, unfortunately. But what are your final reflections?
First, that is just for him to pass away in that hospitalization. It sounds like it's just horrible. That is not the illness script for ALS that I am. He presented obviously very, very late in that disease. The patients that we've diagnosed in hospital with EMG in hospital, they do leave the hospital. Sometimes they leave on hospice, just because that makes the most sense in terms of their goals, but, kind of like do not rehospitalize. But I've actually never had someone get that diagnosis in the hospital and pass away in that hospitalization. So that is just devastating. What I'll say is something that I think we learn and then continue to learn over and over again as internists is, and I suppose as cardiology fellows, though I can't speak to that experience, is this idea of like a type 1 versus type 2 process in terms of ischemia. And what I have found as I've now attended is that it's always possible for type 2 to turn into type 1. And I think that's the thing that I did not appreciate well. And I think oftentimes that gets blown off. But these, the history you actually hear from patients most often for a heart attack, is, I was running or I was biking or I was going up a set of stairs, or, that's how patients think about heart attacks is I was exerting myself so hard and then I developed a heart attack. And I think that as doctors, actually, if we listen to the way that patients think about this, it actually would help, because if you create enough demand on the heart and they have an existing lesion, you can create a type 1 process, right? I mean, it doesn't start off that way, but, and the way that, because it makes sense, right? If someone had, stable angina or worsening progressive angina and all of a sudden they run a marathon and then they drop over in VFib arrest, right? I mean, I think most people are going to think, well, probably they had a heart attack, probably they had type 1, right? But it was brought on by what was probably type 2. And that's really no different than a septic patient, right? The septic patient's not running a marathon, but physiologically they sort of are. A patient with this degree of tachycardia, if that LV, which only has an EF of 30-something%, is pushing against a systolic blood pressure of 190, right? You can at the very least bring out what is a fixed severe lesion, but you can precipitate a plaque rupture, and that's, I think, actually the way that the sort of the general population thinks about it is that way. And so I think, just because someone thinks type 2 right now doesn't necessarily mean, it sounds like in this case it probably was all type 2, but that's just something I've been humbled by in the last year. Patients who come in septic from pneumonia and then the tropes just keep rising, and either it was always type 1 or it was type 2 that then sort of they developed the type 1. So that's the first thing, I think. And I think along the same lines is remembering that sometimes the hypertension, the tachycardia, that sort of, it's actually just a response to sympathetic overdrive. So, I cannot imagine that breathing in the 30s and still being hypercarbic. I mean, imagine what the brain is feeling in that moment, right? It's just, it's still hypercarbic. The CO2 drive is still there because this is not a guy who has chronic CO2 retention, right? So his brain is just screaming to increase minute ventilation. And despite that, he's remaining hypercarbic in a brain that's not used to seeing that. So I mean, again, I'm hand waving a little bit, but that has to be very sympathomimetic, right? And so if you just drive the engine hard enough, you'll eventually mount tachycardia and blood pressure. And then if you have a fixed LED lesion, it'll bring out chest pain essentially. And so those are, I think, my thoughts.
It's a beautiful reflection.
But yeah, very humbling case.
Yeah.
Very humbling case.
I think that walkthrough of the marathon of the patient is performing physiologically, that really hammers home the point I was trying to get across. So thanks for the reflection, Mike. And yeah, my last comment before we sign off is very unusual ALS presentation. The tempo of this actually was a strong arguing point against ALS when neuro initially met this patient. But of course, when they saw the EMG, they had to modify that hypothesis. There are variants of ALS that are very diaphragm centered, which was clearly the case for this patient since he could still walk, but he couldn't breathe at rest. There's something called dyspnea fasciculation syndrome, which I'm not sure if it actually captures the final morbid hypothesis of pure respiratory failure, but it kind of captures that the syndrome. Dyspnea, he couldn't breathe at home. That was kind of his major issue. And then fasciculations, it's very diaphragm-centered disease. So thanks again for playing along, Mike. And listeners, definitely send us your reflections on this tough case. And have a good day, everybody.
Thanks, everyone. And take a look at that video. Those fasciculations, burn that into your brain. You can't miss ALS. That is what it looks like.
I love it. See you, Mike.
Yeah, take care, guys. Thanks. This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.